Rheumatology and nephrology are closely linked due to the involvement of autoimmune and systemic diseases that affect both the joints and the kidneys. Rheumatologic conditions can lead to kidney disease, either directly or as a complication of the disease or its treatment. The most common links between the two specialties include 1. Systemic lupus erythematosus, SLE. Lupus nephritis is a major complication of SLE, a systemic autoimmune disease that causes inflammation in various organs, including the kidneys. Nephrologists and rheumatologists often collaborate to manage SLE patients with kidney involvement. 2. Vasculitis. Systemic vasculitis, such as ANCA-associated vasculitis, can affect both small blood vessels in the kidneys and other organs, leading to glomerulonephritis. These conditions require joint management by nephrologists and rheumatologists. 3. Scleroderma. This connective tissue disease can cause scleroderma renal crisis, which leads to sudden kidney failure and hypertension. Early detection and treatment are crucial to prevent irreversible kidney damage. 4. Rheumatoid arthritis, RA. Although less common, RA can affect the kidneys through amyloidosis, a condition where abnormal protein deposits accumulate in organs, including the kidneys, leading to renal dysfunction. 5. Gout. Chronic hyperuricemia in gout can lead to kidney stones or chronic urate nephropathy. Rheumatologists and nephrologists manage both joint symptoms and kidney complications related to uric acid levels. 6. Medications. Many drugs used to treat rheumatologic diseases, such as nonsteroidal anti-inflammatory drugs, NSAIDs, corticosteroids, and disease-modifying anti-rheumatic drugs, DMARDs, can have nephrotoxic effects, requiring careful monitoring of kidney function. This interplay between rheumatology and nephrology often necessitates interdisciplinary collaboration to optimize patient care, especially in managing complex autoimmune and systemic diseases. Rheumatic diseases can have significant effects on the kidneys, either through direct involvement in the disease process or as complications from treatment. Here are key rheumatic diseases associated with renal complications. 1. Systemic lupus erythematosus, SLE. Renal complication, lupus nephritis. Lupus nephritis is one of the most severe complications of SLE, affecting the kidneys by causing inflammation of the glomeruli. Symptoms can range from proteinuria and hematuria to full-blown nephrotic syndrome and renal failure. Treatment often involves immunosuppressants like corticosteroids, mycophenolate mofetil, or cyclophosphamide. Number 2. Rheumatoid arthritis, RA. Renal complication, amyloidosis. Long-standing RA can lead to secondary amyloidosis, where abnormal proteins, amyloid, deposit in the kidneys, impairing their function. Signs include proteinuria and progressive kidney dysfunction. Medications like biologic DMARDs have improved outcomes for these patients. Drug-induced nephrotoxicity. NSAIDs and disease-modifying antirheumatic drugs, DMARDs, frequently used in RA management, can cause acute kidney injury, AKI, or chronic kidney disease, CKD. 3. Scleroderma. Renal complication. Scleroderma renal crisis. This life-threatening complication causes acute renal failure and severe hypertension. It's often associated with the use of corticosteroids in high doses. Treatment includes ACE inhibitors, which have been shown to improve outcomes. 4. Vasculitis, ANCA-associated vasculitis, polyarteritis nodosa, etc. Renal complication, glomerulonephritis. In vasculitis, inflammation of blood vessels can lead to glomerulonephritis, where the kidney's filtering units, glomeruli, are damaged. Symptoms include hematuria, proteinuria, and progressive kidney damage. Aggressive immunosuppression with agents like rituximab, cyclophosphamide, or corticosteroids is often required. 5. Gout. Renal complication, urate nephropathy. Chronic gout with hyperuricemia can cause kidney damage through deposition of urate crystals in the renal tubules, leading to urate nephropathy. Gout can also lead to kidney stones, uric acid stones, increasing the risk of kidney obstruction. Management includes lowering uric acid levels with medications like allopurinol or febuxostat. 6. Antiphospholipid syndrome, APS. Renal complication, renal thrombotic microangiopathy. APS, an autoimmune condition often associated with SLE, can lead to small blood clots in the kidneys, causing microangiopathy, reduced kidney function, and hypertension. Anticoagulation therapy is essential for managing APS to prevent further thrombotic events. 7. Mixed connective tissue disease, MCTD, renal complication, glomerulonephritis. MCTD, a combination of features from SLE, scleroderma, and polymyositis, can also lead to glomerular involvement, resulting in nephritis. Immunosuppressive treatments are often necessary to control inflammation. 8. Sjogren's syndrome, renal complication, tubulointerstitial nephritis. In Sjogren's, the kidneys are more often affected by tubulointerstitial nephritis, causing impaired kidney function rather than glomerular disease. Symptoms may include renal tubular acidosis and nephrogenic diabetes insipidus, requiring tailored treatment. 9. Henoch-Schönlein purpura, IgA vasculitis. Renal complication, IgA nephropathy. This small vessel vasculitis primarily affects children and can lead to IgA nephropathy, characterized by hematuria and proteinuria. Kidney involvement can range from mild to severe, with some cases progressing to renal failure. 10. Behçet's disease, renal complication, glomerulonephritis, renal vascular lesions. Though rare, Behçet's disease can cause glomerulonephritis or kidney damage through vascular inflammation. Immunosuppressive therapy is the primary treatment for kidney involvement. Key takeaways: systemic inflammation, immune complex deposition, and autoantibodies in rheumatic diseases can cause significant kidney involvement. Rheumatologic drugs, NSAIDs, corticosteroids, and DMARDs can have nephrotoxic effects, making careful renal monitoring essential in management. Close collaboration between rheumatologists and nephrologists is vital for optimal patient care in conditions with renal complications. Primary renal diseases can lead to rheumatic complications due to the systemic effects of kidney dysfunction or immune system activation. These complications may manifest as joint, bone, or muscle issues. Here are the main rheumatic complications seen in patients with primary kidney diseases. 1. Renal osteodystrophy. Cause: chronic kidney disease, CKD, or end-stage renal disease, ESRD. Leads to disturbances in calcium, phosphate, and vitamin D metabolism, causing bone changes. Rheumatic manifestation: osteomalacia, softening of bones due to defective bone mineralization. Osteoporosis, loss of bone density. Bone pain and joint pain are common, and patients are at increased risk of fractures. Management: phosphate binders, vitamin D supplementation, and controlling parathyroid hormone PTH levels. 2. Dialysis-related amyloidosis. Cause: long-term dialysis, especially with hemodialysis, leads to the deposition of beta-2 microglobulin amyloid in tissues, including the joints and bones. Rheumatic manifestation: carpal tunnel syndrome, shoulder pain due to amyloid deposition in the shoulder joints, bone cysts, joint pain, and stiffness, particularly in the hands, wrists, and shoulders. Management: adjusting dialysis methods, including the use of newer membranes and considering kidney transplantation. Gout and hyperuricemia. Cause: impaired kidney function reduces uric acid excretion, leading to elevated serum uric acid levels, hyperuricemia, and increased risk of gout. Rheumatic manifestation: gouty arthritis, which commonly affects the first metatarsophalangeal joint, big toe, but can also involve other joints like the ankles, knees, or hands. Tophi, urate crystal deposits in the skin or around joints, may form in chronic cases. Management: uric acid lowering therapy, e.g. allopurinol or febuxostat, NSAIDs, colchicine, or corticosteroids for acute flares. 4. Secondary hyperparathyroidism, SHPT. Cause: in CKD, impaired phosphate excretion and reduced vitamin D activation lead to low calcium levels, which stimulates the parathyroid glands to produce more parathyroid hormone, PTH. This causes bone resorption and calcium release. Rheumatic manifestation: bone pain and joint pain due to high bone turnover and osteitis fibrosa cystica, a form of bone disease with fibrous tissue replacing normal bone. Soft tissue calcifications in joints, tendons, and soft tissues can also cause pain and stiffness. Management: phosphate binders, vitamin D analogs, calcimimetics, and in severe cases, parathyroidectomy. Hammer 5. Calcific uremic arteriolopathy, calciphylaxis. Cause: this condition is typically seen in advanced CKD and dialysis patients, where abnormal calcium and phosphate metabolism leads to calcium deposits in small blood vessels. Rheumatic manifestation: severe, painful skin ulcers and necrosis, usually on the extremities, but sometimes over joints, caused by calcification and inflammation of small blood vessels. Joint pain, due to associated vascular damage. Management, aggressive management of calcium phosphate balance, wound care, and possibly sodium thiosulfate infusions. 6. Pseudogout, calcium pyrophosphate deposition disease, CPPD. Cause, chronic kidney disease, especially ESRD, and electrolyte imbalances such as hypercalcemia and hypomagnesemia can predispose patients to the deposition of calcium pyrophosphate dihydrate crystals in joints. Rheumatic manifestation, acute pseudogout attacks causing joint pain, redness, and swelling, often in the knees, wrists, or shoulders, can mimic gout or other forms of inflammatory arthritis. Management, NSAIDs, colchicine, and intra-articular corticosteroids for flare control. 7. Avascular necrosis. Cause, patients with CKD or those on long-term corticosteroid therapy, often used in glomerulonephritis or kidney transplant patients, are at higher risk for avascular necrosis, where blood supply to the bone is disrupted, leading to bone tissue death. Rheumatic manifestation, severe joint pain, most commonly in the hips and shoulders, along with limited joint mobility. Management, pain control, physical therapy, and in severe cases, surgical interventions like joint replacement. Number 8, septic arthritis. Cause, patients with kidney disease, especially those on dialysis or immunosuppressive therapy post-transplant, are at higher risk for infections, including septic arthritis. Rheumatic manifestation, acute joint pain, swelling, redness, and warmth due to infection of the joint, often requiring immediate intervention to prevent joint damage. Management, antibiotic therapy, and in some cases, surgical drainage of the infected joint. 9. Osteonecrosis. Cause, reduced renal function or steroid use in kidney diseases can lead to the death of bone tissue, particularly in weight-bearing joints like the hips. Rheumatic manifestation, joint pain, especially in the hips, which may worsen with weight-bearing activities and lead to decreased range of motion. Management, conservative measures include rest and pain relief. Advanced cases may require joint replacement surgery. Haber 10. Fibromyalgia. Cause, the chronic stress of living with kidney disease and its associated treatments, e.g. dialysis, can lead to the development of fibromyalgia, a condition characterized by widespread musculoskeletal pain. Rheumatic manifestation, widespread muscle and joint pain, fatigue, and sleep disturbances. Management, symptom management with pain relievers, antidepressants, and lifestyle modifications, e.g. physical therapy, stress reduction. Key takeaways, chronic kidney disease, CKD, and related conditions often lead to mineral and bone disorders, joint diseases, and systemic inflammatory complications. Dialysis and impaired uric acid handling are key contributors to conditions like amyloidosis and gout. Managing rheumatic complications in primary renal diseases often requires a multidisciplinary approach involving both rheumatologists and nephrologists to balance treatment of the underlying renal condition with control of rheumatic symptoms. Referrals between rheumatologists and nephrologists are crucial for managing complex patients who have overlapping rheumatic and renal conditions. Below are guidelines on when to consider referral in both directions. When a rheumatologist should refer a patient to a nephrologist. 1. Persistent proteinuria or hematuria. Red flag. If a patient presents with unexplained proteinuria, 500 milligrams per day, or hematuria not attributable to other causes, e.g. infection, further investigation by a nephrologist is essential. Possible conditions: lupus nephritis, vasculitis, e.g. ANCA-associated vasculitis, or amyloidosis affecting the kidneys. 2. Declining kidney function. Red flag, a progressive decline in renal function, elevated serum creatinine, or declining eGFR in a rheumatologic patient. Possible conditions: drug-induced nephrotoxicity, e.g. from NSAIDs or DMARDs, glomerulonephritis in autoimmune diseases, SLE vasculitis, or secondary amyloidosis. 3. Lupus nephritis, red flag, any signs of renal involvement in systemic lupus erythematosus, SLE, e.g. proteinuria, hematuria, rising creatinine. Role of the nephrologist. Kidney biopsy to assess the severity and subtype of lupus nephritis and to guide immunosuppressive treatment. 4. Scleroderma renal crisis. Red flag. Sudden onset of hypertension and rapidly worsening kidney function in a patient with scleroderma. Role of the nephrologist. Urgent management of renal crisis with ACE inhibitors and possible dialysis. 5. Vasculitis with renal involvement. Red flag. Patients with ANCA-associated vasculitis, e.g., granulomatosis with polyangiitis or microscopic polyangiitis, showing signs of glomerulonephritis, e.g., hematuria, proteinuria, rising creatinine. Role of the nephrologist. Assess the extent of renal involvement and guide aggressive immunosuppression and potential plasma exchange. 6. Uncontrolled hypertension with rheumatologic disease. Red flag. Hypertension that is difficult to control in the context of a systemic rheumatic disease. Possible conditions: lupus nephritis, scleroderma renal crisis, or amyloidosis affecting kidney function. 7. Unexplained fluid retention or edema. Red flag. New onset of severe edema or fluid retention in a patient with a rheumatologic condition. Possible conditions: nephrotic syndrome due to lupus nephritis, amyloidosis, or vasculitis. When a nephrologist should refer a patient to a rheumatologist. 1. Suspected autoimmune disease affecting the kidneys. Red flag. Kidney biopsy or clinical suspicion of an autoimmune process, e.g., lupus nephritis, ANCA-associated vasculitis, or IgA nephropathy that requires systemic management. Role of the rheumatologist. Diagnosis and immunosuppressive therapy, which may include steroids, biologics, or DMARDs. 2. Systemic symptoms suggesting rheumatic disease. Red flag. Joint pain, rashes, fever, or fatigue in a patient with CKD or other renal disease, which could suggest an underlying autoimmune disease like SLE, Sjogren's syndrome, or vasculitis. Role of the rheumatologist. Diagnostic workup for systemic autoimmune diseases and treatment initiation. 3. Positive autoantibodies. Red flag. Positive serological tests such as ANA, anti-dsDNA, or NK in a patient with renal disease. Role of the rheumatologist. Further evaluation for systemic rheumatologic disease such as lupus or vasculitis. 4. Chronic inflammatory arthritis. Red flag. A nephrology patient showing signs of chronic joint inflammation, especially in the context of renal disease. Conditions like gout, pseudogout, or rheumatoid arthritis may coexist or arise secondary to kidney disease. Role of the rheumatologist. Diagnosing and managing inflammatory or crystal arthropathies in patients with renal impairment, tailoring treatments to avoid nephrotoxic drugs. 5. Amyloidosis. Red flag. Signs of amyloidosis on kidney biopsy or clinical findings of nephrotic syndrome in a patient, especially with systemic symptoms. Role of the rheumatologist. Identifying and managing the underlying cause, which may be related to chronic inflammatory diseases or hematologic disorders. 6. Uncontrolled gout with CKD. Red flag. Refractory gout or recurrent gout attacks in a patient with chronic kidney disease, where standard treatments may be limited by renal function. Role of the rheumatologist. Adjusting urate-lowering therapy and managing gout flares in a renal-safe manner, avoiding nephrotoxic agents. 7. Fibromyalgia symptoms in renal disease patients. Red flag. Widespread musculoskeletal pain, fatigue, and sleep disturbances in a nephrology patient, which could indicate fibromyalgia. Role of the rheumatologist. Diagnosis and management of fibromyalgia, focusing on non-nephrotoxic therapies like lifestyle modification, physical therapy, and medications that are safe in kidney disease. 8. Drug-induced rheumatic symptoms. Red flag. Musculoskeletal symptoms or rheumatologic side effects, e.g., lupus-like syndrome, arthritis, or vasculitis, in a nephrology patient on medications like hydralazine or allopurinol. Role of the rheumatologist. Identifying drug-induced rheumatic syndromes and adjusting treatment. Collaborative management. Joint management. For conditions like lupus nephritis, vasculitis, or amyloidosis, the rheumatologist and nephrologist should work closely together to manage both the renal and systemic manifestations of the disease. Medication considerations. Immunosuppressive treatments used by rheumatologists can have nephrotoxic side effects, while nephrologists need to be aware of how renal impairment may affect the choice and dosage of rheumatologic medications. Key takeaways. Refer to nephrologist when there are signs of significant renal involvement in rheumatic diseases, e.g., proteinuria, declining kidney function, or hypertension. Refer to rheumatologist when a nephrology patient shows systemic symptoms suggestive of autoimmune or inflammatory disease, e.g., joint pain, positive autoantibodies, or skin rashes. Phosphate binders are medications you reduce the absorption of phosphate from the digestive tract, helping to control phosphate levels, hyperphosphatemia, particularly in patients with chronic kidney disease, CKD, or end-stage renal disease, ESRD. In CKD, the kidneys lose their ability to properly excrete phosphate, leading to its buildup, which can result in bone and cardiovascular complications. Mechanism of action. Phosphate binders work by binding to phosphate in the food that is consumed, forming insoluble complex that is then excreted as stool instead of being absorbed into the bloodstream. They are taken with meals to block the absorption of dietary phosphate. Why phosphate control is important. In kidney hyperphosphatemia. 1. Renal osteodystrophy, bone diseases caused by imbalances in calcium and phosphate metabolism. 2. Vascular calcification. High phosphate levels can lead to calcium phosphate deposits in blood vessels, increasing the risk of cardiovascular events like heart attacks and strokes. 3. Secondary hyperparathyroidism. Excess phosphate stimulates the parathyroid glands to release more parathyroid hormone, PTH, worsening bone disease. Types of phosphate binders. 1. Calcium-based binders. Calcium carbonate and calcium acetate. They bind phosphate and also provide calcium, which can help in maintaining bone health. However, excess calcium can contribute to vascular calcifications. 2. Non-calcium-based binders. Sevelamer, a polymer that binds phosphate without increasing calcium levels, making it at risk for vascular calcification. Lanthanum carbonate, a rare earth element that binds phosphate effectively, also without affecting calcium levels. 3. Aluminum binders. Aluminum hydroxide, effective phosphate binder, but limited due to the risk of aluminum toxicity, which can lead to bone disease and neurological problems. 4. Iron-based binders, ferric citrate and sucroferric oxyhydroxide. These bind phosphate and provide an additional benefit of delivering iron, which can help manage anemia in CKD patients. When are phosphate binders used? Phosphate binders are typically prescribed for patients with chronic kidney disease stage 4 or 5, or those on dialysis, as kidney function is severely impaired in these stages and phosphate excretion is greatly reduced. Common side effects: gastrointestinal issues, nausea, constipation, or diarrhea. Hypercalcemia, seen with calcium-based binders, which can lead to vascular calcification if used excessively. In summary, phosphate binders are essential in managing the complications of elevated phosphate levels in patients with kidney disease, particularly to protect bones and cardiovascular health.